So I'm going to take you through, kind of what it means to be interoperable, kind of the high level, big picture stuff, and then I'm, going to, dive into some of the technical details, and then we'll jump into awards, REHR, and I'll show you what it actually looks like. So go ahead and get started. So big picture, what is interoperability? It means that we're connecting systems, but on a fundamental level, I like to think of interoperability in terms of use cases. So I think the most important thing to keep in mind with interoperability is that we're actually connecting providers with providers and connecting providers with patients so that everyone's working with a patient's or consumer's most up-to-date medical record. Another key detail for with interoperability is that it gives everyone standards that theoretically we're all working, speaking the same language, and we're working with documents like the CCDA 2.1 that, my CCDA is the same as Jim's system's CCDA, so that when we exchange that document between systems, Jim can take details out of that document, pull it into his EHR, and I can pull details of the document and pull it into my EHR. Does this actually happen in practice? Most of the time it does, but you could still, have the same, document technology and have to kind of do a little work to get it to work. So everything is not perfect yet, but I'd say 99% of the time everything works out, and we're able to help agencies exchange information. And then we're connecting systems using common protocols and creating relationships of trust. So this is something that I think is really important to understand with interoperability, and how it's different from maybe other types of interoperability outside of the healthcare world, like stuff as simple as like email or Google Drive. But it's fundamentally important with healthcare interoperability that we're creating relationships of trust, so that when I send something to Jim or another system, I know that when I'm sending him that information, I know it's going to Jim's system, and that I know that Jim is the person that's reading that information. So that happens kind of in an end-to-end way with technology like encryption. But when someone's participating in interoperability, there's legal kind of mechanisms at work. It could be as simple as a client completing a consent form, but it could also be as simple as the HR person at an agency verifying someone's identity, so that when they go in to access that information, it's actually that person and they're authorized to access that information. So it is technological, but it also, I think of it beyond that as well. So what are the goals for interoperability? I think in an abstract, a lot of people think interoperability is kind of this infinite spectrum where you can just, infinitely exchange information between systems. And I think that should be a goal, but it's not the case right now, at least in how interoperability is defined, which is, I think, the definition we've received from the primary care system, where hospitals are sending data to health information exchanges. So the interoperability goals are to keep a consumer's healthcare record up to date for all participating providers. And I'll talk about how that actually happens. Allow reconciliation of a record into an EHR. So that means that you're able to pull a record back from maybe a health information exchange that you're working with. Get real-time alerts about consumers. So if you have a consumer that has an emergency department visit, which we don't want to happen, but unfortunately is kind of it's the business we work in. You want to know about that so that you can take action on that, whether it's physically sending a program supervisor down to check on the consumer, or when they're released, making sure you have all the details from their emergency department visit, and you're able to pull those details back into your EHR. You're going to want to contribute data into the healthcare system for quality improvement. I think that's a big thing that's happening right now, which is, I think, really great. There's I think a huge benefit to the behavioral healthcare community intrinsically, that I think it really shows healthcare systems and Medicaid revamp projects how important behavioral healthcare agencies are to the healthcare system. I think like the hospitals are under so much pressure to cut emergency department utilization, and I think behavioral healthcare agencies could play a huge part in that and kind of really represent themselves well by sending data in to show that we're providing these services to consumers after their ED visit, and hopefully they don't become emergency department recidivists. And then finally, I think this is a big goal, and this is really coming from CMS right now, is to give consumers control of their healthcare records. We hear this a lot from CMS that if consumers have control of the records, they can make better informed decisions. I think that's true to some degree. I'm not sure the technology is there to support that yet, but I think that this is very well attuned to behavioral health care, where there's so many tremendous people at our agencies who now have the opportunity to use an EHR-like awards and view a consumer's healthcare record with the consumer and then help them make informed decisions. I think that is unbelievably powerful, and I think working together with your consumers, agencies should be able to really make use of this technology to cut down on duplication of services. If a consumer needs to go to a specialist, send them to a specialist. Cut down on hopefully they're not opioid shopping, but cut down on maybe the number of meds they're taking, reconcile their medication records. The opportunities are all out there by using interoperability. So technically speaking, how do we do this? Oh, and I just want to mention, if anyone has any questions at any point, just let us know. I'd be happy to answer them. And Jim, if any questions come into chat, just give me a heads up.
Yeah, absolutely. I'm monitoring the chat on the Zoom, so if folks do have questions, I'll stop and jump in. So
awesome, cool. So what in the abstract, like what are these types of connections? So there's a few prominent types of connections. So I think the first is health information exchange, and this is what I think everyone might be most common with. It's called different things in different states, and different states have different numbers of them, and some are public and some are private. But health information exchange is a organization that has it's kind of like a data warehouse system that supports inbound connections and outbound connections from a lot of different healthcare entities across the healthcare providing spectrum. So, hospitals, behavioral healthcare providers to primary care providers. And it's what I would call a hub and spoke connection, meaning like the health information exchange sits in the middle, and we're going to send records to them, and we're also going to be able to pull records back. And then many health information exchanges provide additional services such as analytics or being able to provide alerts so that you can get information on population health, but you can also if someone else in their network has an encounter with one of your patients and they're able to do the very difficult job of patient matching, then you'll be notified about that, and also be able to then pull a record back from that health information exchange. We're also seeing a lot of instances where health information exchanges are interoperating with each other. So like in New York, we have something called the Shiny, where all the health information exchanges theoretically should be able to communicate with each other. Other states like New Jersey are taking a backbone approach. They have something called NJHIN, which I understand is forthcoming, where that someone like Foothold will be able to connect into that backbone and then work with the other health information exchanges. So there's a number of different approaches to this. Another one is the single entity approach that North Carolina is taking. I know Maine has a similar single entity approach. So suffice to say, every state is taking a different approach. There are some national networks as well. And then there's private ones where different hospital systems might have their own health information exchange for participating providers. The federal government's taking the approach where they want to cut down on the walls. Like they want information to be pretty free flowing. There's legislation called 21st Century Cures, and a rule called TEFCA that's coming out of it that's going to seek to break down some of those barriers. I don't know exactly how it's going to affect behavioral healthcare right now because the walls aren't fully up for behavioral healthcare. I actually think that because a lot of behavioral healthcare or many behavioral healthcare agencies bill Medicaid, states have taken a particular interest in making sure information can flow and that agencies are funded to take advantage of these networks. But it's going to be interesting to see how that shakes out. I think it hopefully will result in more behavioral healthcare providers having the opportunity to connect to health information exchanges. Another type of connection is direct. So this is more like sending an email, but it's a secure healthcare message. And it uses a network built on trust. And the awesome thing about direct, which the specific units are called HISPs, which are health information service providers, the HISPs can all speak to each other. So if I send a message, we use a HISP called MedAllies, for example, and I want to send a message to someone who's using a different HISP, I can just send that message through Awards and they'll get it. And likewise, if they want to send me a message with someone's healthcare record, I'll be able to receive that and interact with that message. And then finally, there's RESTful APIs. So interoperability is going to be moving to a technology called FHIR. And FHIR is, there are many different versions of it right now, but it is going to make it possible for and allow agencies to more easily connect with each other. And you know, just so we all know, FHIR stands for Fast Healthcare Interoperability Resources. Not a great name in my opinion, but it is kind of the future, and it should make exchanging data between systems a little easier, hopefully. All right. And then I just want to touch on a few other ones. There's proprietary APIs that are out there. There's also an API called the MU 2015 API for consumer directed exchange. As I kind of mentioned before, consumer directed exchange is out there. There's not a ton of technology that's out there to support it yet. But I hope it gets to that point because I think it really will be really powerful if you go see a provider and you get your healthcare record on your phone immediately following that. I will say Apple has done a really tremendous. I'm not like a huge Apple fan. I have an Android phone just for reference, but Apple has done a tremendous job with Apple Health of actually using FHIR to establish connections to a lot of healthcare systems and providers, so that does actually make it possible. Where if you were to go to, like I'll use Kaiser as an example, because they had a great ad on TV last night, so they're at the top of my mind. If you go to Kaiser Permanente in California, and you can then use Apple Health to get your record out of their system.
Hey, Alex, do you mind if I jump in? I'm going to ask a
Absolutely.
question. It's a little bit of a summary question, but we had a little dialogue. When you talk about interoperability, is that the same or different than just an integration, if you will, with another system? I guess that we have all these different connections. Like, does that mean we'll be able to integrate with any system, or is there sometimes I get that question a lot from folks about, well, hey, if I'm interoperable, I can connect to anything. Is that?
That's a great question. So I think a lot of what we would call integrations that have taken place aren't interoperability. They're proprietary. They don't use open standards or open software, but they get the job done of letting you see clients between systems. Interoperability, in my mind, is a step above that, where you're using standards and specific mechanisms to send data between systems in the overall healthcare system. So not to solve like one-off problems. So in my mind, they're two different things. I think they have the opportunity to merge into the same. I've seen just, working with like Medicaid revamp projects in New York State, for example, where other companies like GSI, for example, are talking about using interoperable standards to kind of create what used to be an integration project. So I think hopefully we're going to get away from those proprietary integration projects, and interoperability will start to take over. But it really depends on the data set. Interoperability is really talking about a specific data set, whereas those integrations might be looking at other types of information.
Great, thanks.
You are welcome. So in terms of steps to get connected, this interoperability isn't solely on the vendor, and it sometimes requires agencies to adapt and kind of change how they work. It's a different mindset. And you're also going to be working with other vendors external to your EHR vendor. You're going to be working with potentially an HIE vendor as well. So it's really important to keep all that in mind. So I've just outlined some steps to get connected. I hope this isn't intimidating to anyone thinking about this, but I just wanted to lay it all out there. Just because at Foothold we have a ton of experience with establishing these types of connections. So number one is contracting. I used to kind of take this for granted, but it is actually a huge deal. And depending on your agency, there could be issues. So I think it's really important when you dig into this. You look at you're either going to have a BAA or a data sharing agreement, and it's either going to be with with your EHR you probably already have a BAA, but with the RIO or HIE you're probably going to have a data sharing agreement. Or you may have a BAA specifically with them, and then like the EHR vendor and the HIE will have a data sharing agreement. It's just really important to. Sorry, Jim, was there a question?
Yeah, I have a quick.
Sure.
What is a BAA? I'm asking more for me than anyone else. So
Yeah, that's a great
just so it's
question.
clear.
Thank you. Any acronyms I should be explaining? It's a great point. BAA is a business associate agreement. It is essentially an agreement that establishes a relationship between the two parties and has terms like, heaven forbid there was a breach. What happens, who's responsible, what's the time frame for remediation, all that great stuff that you hope to never have to deal with, but you're entering a different world where you're now exchanging data between systems, and it's really important to have one in place and know what the terms are. Another thing you're gonna have to deal with in contracting is hopefully you're being provided incentive dollars to do this. You should understand what's expected of you from that incentive agreement. There's probably going to be data quality standards. There's going to be a time frame. There's going to be, are you using certified electronic health record technology? Just know all that stuff going into it. I've seen agencies sign blindly and then have to do a lot of work to make it up. And if you're not ready for that, it's not to say you shouldn't do this, but just you should get ready and know what the expectations are. Another thing is database configuration. So Awards is awesome in that we started as what I would call behavioral healthcare case management software, and we still do a really great job of that. But in 2011, the federal government came up with the Meaningful Use Incentive Program, which is gone now, which is it's interesting. I have mixed feelings about it because we put a lot of work into meaningful use, but its legacy is fully here. The federal government is still certifying software as certified electronic health record technology. And that means that even though software like Awards has a sweet spot as being the software for behavioral healthcare agencies, we're also a fully certified EHR in the same way Epic and Cerner are. So we can connect to systems like that, or we can exchange data with systems at that level that are enterprise hospital environment. And to me, that's really cool. But it also means that when you're thinking about interoperability, you also need to know that you're using a system that's certified. There are non-certified systems that in some regions are allowed to connect, but I can tell you firsthand that that gets really messy really quickly. And it can just cause issues up and down. So I would always, if I was doing interoperability, I'd always suggest using certified software. I don't say that as a Foothold employee, and it's just really important. Another thing is consent. Each state is kind of working this out right now. The default for most states have been that they're an opt-out state for consent. Consent meaning that your consumers are selecting whether they're going to allow you to send data on their behalf. So the opt-out model is great, but some states, as they start to dig into this, are changing. They'll flip to opt-in. New York, for example, is an opt-in state, meaning that you're going to have to collect consent electronically, so that's in your EHR. And how do you do that? In Awards, you can collect electronic signatures, and that's how we handle the consent forms. So you're going to need hardware to be able to collect those electronic signatures. It is like it's an important. It's like not integral to interoperability, but it is in a lot of ways because it makes it possible for you to actually send data to the other system, and then allow and give yourself access to access their data in that other system. Technical reconciliation. This is kind of a step that the EHR vendor is going to handle with the interoperability entity. And I just put 1 + 1 does not always equal 2, because I've been down the road a lot where you'll exchange specifications, and when you actually dig into it, even though your specifications might match, there's little details that don't. So it's really important to give a lot of lead time to both vendors to look into that, so that they can make sure their systems can speak to each other effectively. Um, just along those lines, that has to do with the tunnel and documentation exchange. So generally, two systems will set up a virtual private network, or a VPN, as kind of like the tube between the two systems. And then when we talk about document exchange, we're going to use standards like ADT, which is an HL7 standard. HL7 is a healthcare organization that creates open standards for document exchange. And we're going to use a document called the CCDA, which I'll show you exactly what that looks like in awards. The CCA has specific domains, so like demographics, medications, allergies, problem list. We're going to make sure all that stuff gets sent to the other entity. We always make sure to test connections before we go live. And then once you go live, this is a major step. You're just going to have to make sure that if you're doing a behavioral healthcare workflow, you're now going to have to kind of adopt more of a primary care workflow, so that you're hopefully tracking data elements that get into the CCDA that maybe you weren't tracking before. And in terms of data quality, in an interoperable world, these systems don't really work by like breaking down natural language. So if you have a diagnosis, a system is going to care less about what the name of the condition is, and way more about what the code is behind that condition. In awards, we use a few APIs to make sure that every record you put into awards in a medical module gets coded. It's extremely important to us, and it's extremely important to interoperability entities. And I have here at the bottom, be audit ready. You should make sure that your records are complete and that they're coded, because you could get audited by any number of different organizations when you're participating with interoperability, because they want to make sure the data you're sending is coming out of your system as you say it is. Because if you think of the job the health information exchanges are doing, it's a huge burden, because they have to kind of take everyone at their word that they're sending good, high quality data, because then they're reconciling that into kind of like your quote unquote one record, so that it's the most up-to-date record that's ready to be retrieved by the next provider that needs it. So it's really it's kind of a beast of a job, but they do a great job of it overall.
Hey, Alex, I have another question if I can jump in.
Sure.
The coding you're talking about, is it any harder or easier for like behavioral health and SUD agencies versus like a primary care? Like I mean, it seems, I know we're in a different sector than a primary care, but what's your sense on that?
If I think that's really the beauty in using a certified system, because if you're using a certified system, you're meeting the same set of requirements that a primary care system would be using. So we're handling coding in a very similar way, but within the behavioral healthcare workflow.
Okay.
If you're not using a certified system, that data could be getting coded, but it's anyone's guess.
Okay.
Cool.
And we have another question. It says, what kind of certification are you referring to? I assume from the prior slide.
Yeah, it's a great question. So the certification is still called Meaningful Use Certification. And the latest edition of that is the 2015 edition. So if you go onto the Foothold website, which I can do, and then you scroll down to the bottom, we have it says ONC Certified 2015 Health IT Module. And then when you click on the link, we're actually federally required to have this page up in this format. You'll get all the information about our certification, what additional software is required to make it work that's included in the certified edition, any additional costs, they're all here. So if you're curious, it's awards. The link is footholdtechnology.com award software / meaningful use. But you can also get to it by clicking on this logo down here. It's a great question, though. Cool. So how do you get started with interoperability? Number one, I'd say check for incentives. I think there are great reasons to get connected, but I will say I know the way that a lot of behavioral healthcare agencies operate, and you guys are focusing on serving your clients. Um, and a lot of the gains here are for the overall healthcare system. So I will say, while interoperability will absolutely improve the way you guys provide care, since you're going to be helping the system as a whole, and a lot of government agencies are paying for you to get connected, make sure you look out for incentives. Or on the other hand, in terms of carrot stick, a lot of regions are now seeing mandates. So you might be incentivized, you might have a mandate, you might have a mixture of both. But look out for it and try to try to try to maximize your opportunity in this area. It might be in terms of working with a Medicaid revamp unit, like in New York, we have the PPSs. You might be in New Jersey where they have the NJ SUD program. There's a lot of different programs out there. Work with your partner agencies and partner organizations to really maximize your opportunity there. Another thing is get in line. The HIE entities are not all ready to onboard everyone at once. There could be significant lead time for it. So, I hate to say get in line now to connect next year, but that's the unfortunate reality in some areas. Depending on the availability of the health information exchanges resources. There just really aren't a lot of interoperability developers, to be perfectly honest. That's, I think, the main reason for that. Understand the data collection demands. So I kind of was alluding to this before, but oh, sorry, Jim, is there a question?
No, sorry.
Okay.
Go ahead.
Okay. Understand what's in the CCDA, which I'll show you shortly, and understand what your consent collection needs are. Assess if you're going to have to purchase e-sign hardware. We have a video that we send around at Foothold about the different devices you can use, from touchscreen monitor to a tablet. The costs start around $100 and they go up from there. So if you do need to collect electronic signatures, it's kind of a real-time thing. So you need to be sitting there with the patient or consumer and do that. And then understand any additional costs that there might be. Sometimes the health information exchanges require you to pay. Sometimes you might need to, hire a consultant to assist with this. There's just a lot of, if you upgrade your EHR to be the certified version, there are costs. There's costs to connect on the EHR vendor side. Just kind of assess that and then weigh it against the incentives and, what your horizon for having to connect is. I think we're now at an inflection point where agencies see the need to do this and to get integrated into the broader healthcare system. And I think the cost benefit analysis is positive. I don't think it's prudent to wait anymore. I will say, there were early adopters who probably paid a lot of money to get connected. And the efficacy for that a few years ago was probably less than it is now. But right now, I think it's a net positive to get connected. So then I want to go into some of the, things like considerations for each of the parties involved. So we have the electronic health record, the HIE, and the agency. So on the EHR side, we're, things to think about. Does the EHR have an existing hub connection? Is that even possible? So when we say hub connection, that means, if I'm connected to Healthix, which is the New York City RIO, we might have 30 or 40 different agencies all on that same connection, which makes it easier if you're not the first agency to onboard there. On the other hand, there's HIEs where, they have been very, they aren't very open and haven't connected with a lot of agencies. So you might be the first, and just know if you're the first, your time horizon is going to be stretched out a little more. What protocols do the EHR support? So the really cool thing about certified software is there were a set of standards required from that 2015 edition. So the typical foothold interoperability model is using something called an ADT message or a XACML message to send demographics and consent information. We then send the health record itself as a CCDA document. And then we receive alerts using the direct messages. So it's kind of this like single stack. And then the question for the HIE is, are they doing the same thing? And then what are the configuration changes you're going to have to make to your version of the EHR if you're not newly implemented? I think this is a significant consideration because you may have workflow changes involved with that. And I know agencies are very sensitive to that. I am personally sensitive to that as well. I know it's a big deal to change how you operate on a day-to-day basis. And then I think this becomes less of a concern once you start using it. But what are the triggers for messages being sent? In awards, the awesome thing is once you complete the consent, you're never going to touch kind of the HIE connection again unless you want to retrieve something back from the HIE. Everything happens seamlessly. That isn't the case in every system, so it's just good to know holistically how are messages being sent to the other system. On the agency side, some considerations that I kind of pulled out. What programs will send data? It's a big consideration. Are you going to send for all programs? If you're a substance use agency, you have to have 42 CFR Part 2 considerations, as you do right now. I think there's a general there's been a general shift on that, and I think substance use data maybe not more freely accessible, still be protected, but hopefully we'll be able to flow a little easier because it is still good information for providers to have. As an agency, you should be asking yourself, are we collecting the required data set, and does that data meet the data quality standards of the other entities? When do we touch consumers for consent? It's important. I know there's a lot of agencies that now like do telemedicine, or they may not physically meet with the consumers, but it's important because otherwise you're going to have to make alternate arrangements for collecting consent from a consumer. And then this is a big deal, and I've noticed this with every big shift in EHR technology. And this is even a bigger problem in primary healthcare where doctors are more resistant to EHRs. But what's the required to improve care with kind of cost benefit analysis? You're going to be asking your providers to just be doing a little more data collection and a little more work in order to enable these workflows. And you really have to get buy-in. Maybe buy-in would have been a better phrasing than use case acceptance, but it's really important to get buy-in. Some agencies are really harsh about this, and they're like, get with the program or get out. I think it's possible to be nicer about that, but you're really more fully investing in using technology to support your patients. And then the considerations for the health information exchange. Is the health information exchange bidirectional? That means, are you sending data, but also do you have the capability to receive data back? That is not the case for every HIE, which has surprised me on this kind of interoperability journey we've been on. Do they send alerts? I think the alerts use case is just a gigantic one for behavioral healthcare. I think once we enabled that use case, I've seen really the most buy-in, because now the data you're sending out and getting your consumers logged into the system, you're getting a huge benefit back. Unfortunately, behavioral healthcare consumers, I mean really all patients and consumers, have contact with like the emergency department, other parts of the healthcare system for acute care, and it's important you get notified about that. Yeah, go ahead, Jim.
Alex, I had a question. I think it's better if you expand on it. I try to answer a little bit in the chat, but the question was about HIE, the information. I'm going to ask the question. Hopefully, I ask it right. It says, will the system automatically pull the data and send it to the HIE? Like, I assume they're talking about like our system, right? Where we would automatically. That's that trigger you were talking about.
Yeah, that's the triggers. Yeah.
Okay.
I was trying to be EHR agnostic. Awards automatically sends it. We have a really great piece of documentation in our help system that explains every action you can take to send those triggers. But yeah, anytime you interact with the patient, any data that's in the electronic document, we're going to push that automatically. That is not the case with every system, so I just wanted to be crystal clear with that, to set that expectation.
Great. Thank you.
So some of the HIEs have portals where you can kind of do some value-added work, look at population health statistics, get more in-depth information, which is great. And the cool thing about that is that the consent that's being sent from our system to their system enables you to access your consumers. So like you wouldn't be able to access anybody. That would be crazy. But you could look at other information about your consumers in their portal. And then a big consideration is, does this HIE interoperate with other HIEs? That's more of a state-to-state thing, but it's still good to know. Some of these HIEs are very region locked, I would say. So it's important to understand if you can get data from other sources. I think that's going to be particularly big with some of the opioid projects that are coming out on an HIE level, but also with the PDMPs, which are the pharmacy management systems, where if an opioid or a controlled substance is prescribed, a pharmacy is going to have to log that information. It's important information for behavioral health care providers to know and work with. So what is the award certified edition, kind of pivoting to some award specific stuff? So like I mentioned, awards has been federally certified since 2011. There have been three editions. If you I kind of think of this like Microsoft Office, like there's Office 2011, 2013. I don't remember the exact years, 2010, 2013, 2016. That's kind of how the certified edition works. And sometimes the years don't actually correspond to when the certification is taking place. So it's for certified edition, it's been 2011, 2014, and then 2015. And they've been 3 years apart. So obviously 2015 is the odd duck there, but we certified to the 2015 edition as soon as we possibly could, which was in 2017. So we're good for another 3 years.
So there's not a 2019 version.
There's not a 2019 version. In fact, I've been on some kind of like hybrid industry federal government calls, and supposedly the next version is going to be called 2015A. So go figure that one out. I'd push them to maybe come up with a better name, but I have other things to worry about. Our certified editions, interoperability enabled. We stick to all of the standards that are part of the 2015 edition, and then beyond that, we have a consumer-facing API, which was a big deal. This is a big requirement that certified software has to have. We're coding all of your data, and we're using a product called IMO, and then another one which is actually a National Institute of Health product called RxNav. So we're providing you with codes for all medications, diagnoses, lab orders, and procedures. We use like SNOMED, CPT, LOINC, DSM, ICD, and ARCS-Norm. We're logging data into all of the required CCDA domains in what we've created as an encounter-based workflow. And I think, not to pat ourselves on the back, but we've done a really great job of integrating this as closely as you possibly can into the behavioral healthcare workflow, keeping in mind we basically built an EHR inside of a behavioral healthcare case management software. So the two are very tightly integrated. And we have like some really specific behavioral healthcare features. One is called care plan mapping, where we can literally take parts of your care plan and map it into the CCDA. And we've seen some use cases of that already that have kind of surprised us. We did it in a way to allow clients to do it dynamically to meet whatever need they had. And they've gotten pretty creative with that. So if you have like a goal, you can pull that into the CCDA, and then another system can go pull that goal from the CCDA into their own system. So that has been pretty cool. So if there are no other questions, I'm going to go ahead and jump into awards and show you guys what this looks like. Yeah, let's go take a quick look. So I'm going to start with our encounters module, which is in our medical module. The reason I like to start with the encounters module is because it really is a great demonstration of the fact that awards is a relational database, and it's going to allow me to work with data in a lot of different areas. So I'm going to pick.
And just if Alex, if you don't mind, just to add for
Yeah.
this context, we as we were presenting this, we felt like being able to show like, hey, what does exactly mean to put in information and how it goes to an HIE would be useful. We are trying to be software agnostic on this conversation, but this is at least to give you a framework of something of how it works. So I just
Yeah,
wanted to put that out there.
that's a great point. And I agree with that sentiment. Um, so I'm going to just enter a start time and end time. You can see that this is an IMO field, so I could either enter like office visit, or if I know the CPT code, I can just type it in, hit the button. And then the great thing about IMO is it's going to map things dynamically based on the descriptor I'm selecting. I think this is really cool because you can see that SNOMED is a way more granular code set. So you can see that an outpatient visit is giving us the same CPT code as some other descriptors, but the SNOMED code is different. So I'll just pick that one. This client's not real, so it doesn't matter. For provider, I can go ahead and start typing, and it's going to autocomplete. It's going to fill in a lot of this other information dynamically. I'm going to be pulling from our diagnosis module, so I can set the diagnosis at encounter, which is a specific data point separate from just your active diagnoses. Got other fields here that are relevant to the CCDA, but I won't waste your time with that, and I'll go ahead and click save. When I click save, I'm now going to see these other modules on the side, and this is really great because I can now just jump in to edit allergies. I can edit diagnoses, if there's lab orders or medications. I can just jump in and edit these as I see fit, and they'll be updated in the client's record. And the reason that's really important is because when I come here, there's two actions we generally recommend. And I also want to say is just talking about those triggers, just by saving that record, we have now sent a new CCDA to the HIE. So we are completely up to date. So I could either now click generate progress note for the selected record and go write my note off of the encounter, or I can click this one, which is going to generate our clinical summary. And this is going to take us into what I call the VDT screen, view, download, and transmit. And from here, I'm going to have the opportunity to view the interoperability document, download the interoperability document, or transmit it. So if I click view first, it's going to take me into the CCDA viewer, and I can physically and visually interact with the CCDA here. And like, while this is similar to what you saw in awards, this is specific to the interoperability document. And this is the document that's getting exchanged between systems. So it's just really important to kind of take that as its own thing, because the interoperability document and the information that's in the EHR, while it's the same information, the structure of it is different, and sometimes the way it's organized is a little different. And that's how the other systems are going to be interacting with that document, with the document. And likewise, if you pull a document back in, that's how you'll be interacting with it. And then finally, the last button here is transmit. So I know I mentioned a while back the direct kind of use case, but here you'll have the opportunity to send a direct message to another system. So if you like wanted to send it to another foothold client like RSS, you just have to start typing and their direct address will come up. You know, likewise, if you just type Smith, that's probably a mistake because there's so many Smiths. This query is going to take a little while. You can send a message. You can kind of find your Smith provider out of the first 20 and send that along. I think this is really cool. We update this directory is pulling right from our provider MedAllies. So you can send to anyone else who has a direct address, and there's hundreds of thousands of providers who have direct addresses. And kind of an unintended benefit, just from my experience of getting awards and foothold clients up on interoperability, we're now in a situation where foothold clients can exchange data between systems by using direct messaging, which is really great. We're really excited about that. So that's the interoperability document. The other big use case I just want to show you is incorporation. So let me a look at Hank Aaron. So I'm going to go to Hank's face sheet. I'm going to pick a Hank that's in a program. There we go. And I'm going to go down to the clinical documents section down here. And you'll see we have the incorporate button. We're on a test site, so this is not going to work perfectly. You can see on the right side, it should be listing the details of the document. But you can see we have checkboxes on the left, and we would have on the right for including and excluding records based on an incoming document that we're retrieving from another system. And we're going to let you very quickly choose what you want to keep and what you want to remove and what you want to add, and then you can instantly make changes to the record. We do only give that by permission, but I do want to throw that out there because it's a big use case to be able to pull down an up-to-date health record from a client.
And that would automatically change the data that would be in their system then, right?
Exactly, and you could do it quickly.
Wonderful. Wonderful.
And then the kind of, actually I'll skip ahead. So in terms of retrieving that document to incorporate it, you know, I took these as screenshots because I had to grab them from a client database and then redact their name. But you can kind of see, you can pick which network you want to retrieve it from. And then you can pick the document you want to pull down, and then you would incorporate it. And I just want to shout out Healthix because they're a great partner of ours, but because they go beyond just giving you the document as a static document. They always have what's called the current document because they're always updating it based on data from different sources, which I think is really important and a really great feature they have because you don't have to rely on other people to make sure it's up to date. Healthix is taking those steps for you. And then just jumping back, I'm a horrific artist, but some of our clients have found this diagram strangely helpful. But I just wanted to show how alerts work in awards because I think, like I mentioned before, I think that's the single biggest use case that our clients have really latched onto. So you can see we have our awards agency, and they're sending consent and demographics and patient health information to the HIE or RIO. And then in red, we have our event that happens. So let's call that an emergency department visit. The HIE is then sending an alert to our HIS provider, so MedAllies. If you think of it in like more simple terms, you can call them Gmail. And then MedAllies is going to send that message back to the proper people at the awards agency. And I just wanted to put on screen what those messages look like. You know, they're really rudimentary, but they're really powerful because you're getting in real time that X patient with date of birth and MRN was being sent to has been, you know, admitted to the emergency room. Other HIEs will sometimes attach a record as well, but it's really giving you a lot of opportunities there. Jim, anything else you'd like me to show in awards before I talk about some of the other work Foothold's been doing?
No, but so Alex, a couple of things. One is, if you don't mind, I'm going to steal your show a little bit, and then I'll let you jump in if that's okay. One is, we had a question earlier about an integration or with a New Jersey system and things like that. I know we have folks from different states, but I just want to answer this question sort of in a general sense. We are able to integrate in other ways. This is an interoperability specific kind of conversation, so there's some components in here. Not all systems are able to integrate, and so I want to be super careful as I answer this, but there's two general questions I always like to ask folks before we can even have this conversation. So the first one is, can that system integrate? And if so, how do they integrate it? If you think about it as like a conversation, it's like, what language are we going to speak? And then the second kind of conversation is what data needs to be exchanged? And then from there, once we get those two pieces of information, we can start to get into a little more substantive conversation of that. But a lot of times when I talk to agencies or groups and they're like, well, we need to integrate with this system, it's like, okay, well, can they integrate? And then that conversation goes, well, no, they can't. Well, then there's no system, Foothold, any other system that's going to be able to integrate with them. So, Alex, I don't know if you want to add anything to that, but I just wanted to highlight that because it is a
right. And I think that
a lot of times.
Yeah, and that strikes to the initial point I think I tried to make, is that there is a big difference between between interoperability and integration, and that interoperability really means something specific to the healthcare system, whereas integrations are kind of proprietary one-off things. And I think it's been unfortunate that behavioral healthcare software has pushed a lot of people or a lot of agencies to do kind of integrations. And I hope interoperability helps bridge that gap, because I think the biggest thing with interoperability is we're really talking about open protocols and open systems and standards that people are sticking to. And, you know, just as a vendor, when we're able to do interoperability, it means we're able to leverage a lot of the work we've already done, and not have to do one-off customizations. And when we have to do integrations, it really takes us away from our mission of developing great software for you to use. And that's nothing that agencies have control of. It's just an unfortunate fact of how we have to do business right now. But I do think like standards like FHIR are going to do a lot to close the gap there and make it a lot easier to exchange data between systems. That's hopefully what happens.
Hey, Alex, I have a couple other questions that have come in since we've been talking, so I'll ask. I'm just going to ask verbatim
Sure.
here. So one is called, if we were in New Jersey, it sounds like there isn't in New Jersey HIE. Is that correct?
No, that's not the case. I think there's 8 HIEs in New Jersey, but NJII, who we've been working with since 2012, when they were New Jersey High Tech, and we really love working with them. They have an ambitious project called NJHIN. I think if you Google NJII, NJHIN, you'll be able to find it. NJHIN stands for New Jersey Health Information Network. Jim and I have been communicating with them very closely and annoying them as they work to finish their project. But what NJHIN is going to do is it's going to let vendors like Foothold tap into all of the HIEs on their network. I personally think that's the smartest possible approach to take. New York, for example, they started with 9 HIEs. I think we're down to 7 public ones because they keep merging and consolidating. I really think the New Jersey approach is smart. We just haven't really seen the fruits of the labor there yet. I think I know they're going to have to open connections up soon because they have incentive programs that are going to force behavioral healthcare agencies to connect. We have a lot of awesome agencies in New Jersey. I can think of a few off the top of my head that are like really cutting edge. The fact that they haven't asked us to connect is indicative of kind of the environment, but we think that that's going to change this year, and we're really excited about it. But yeah, I do want to. New Jersey does have multiple HIEs. They have public and private ones, but like in such densely populated states like New Jersey, where you might have a large service area, you really don't want to have to pay to connect like 3 or 4 times. There's kind of this, it's called like there's a conundrum called the border doctor. And I think it's applicable to agencies as well. But if you're like a doctor that's like on the border of 2 different service areas for HIEs, it would really be unfortunate that you would have to connect to more than one. So New Jersey, I think, has a great solution for that. We've been working with them for a long time, and we're excited to have the opportunity to implement that.
All right, I got another one, and I'm gonna modify the question a little bit. It says, if we work in New Jersey, and I would add, any other state, then can we? Then would we be able to link to hospitals?
Yep, that's exactly what this is going to let you do. You're going to be sending data to the HIE. Hospitals can pull from that data. If someone goes to the hospital, you'll be able to pull the record back down from the HIE that the hospital's added to that record. So, and then alerts will come from hospitals through the HIE as well. So yeah, that's 100% the goal there. And we would ideally want you to send data with other providers, but I think hospitals are the big picture here.
Great. And Alex, I know you're going to finish up. If anyone else has questions, I think you and I can stay on a little bit.
Yep.
We'll stay on here, but we want to wrap it up by 2. We know folks have got a lot of work to do, so I'll pass it back to you here.
We're almost exactly at an hour.
Yeah.
Good job on timing. Cool. So just a little about like Footholds work, because I think like we do have a lot of experience, and I think that experience is agnostic across different states, because like I was saying, interoperability is very standardized. It's a lot different from a lot of the other kind of connections and integrations people might be working on. So we've been interoperable since 2012. We're connected with almost every HIE in New York. The one we're not connected with is the westernmost HIE. We don't have any clients who've asked about connecting there. We're currently queued with the North Carolina HIEA. We have an ongoing relationship with New Jersey Innovation Institute, and we're discussing the NJ-HIN connection with them. The good news is we've already done the specification reconciliation with them, and they meet the specifications that we have, and we meet their specifications. And we are also interoperable in the 50 states and Guam and Puerto Rico with Med Allies, meaning that you can still do those direct connections even if you're not connected with the HIE. And that also means that if you have a consumer in a HIE portal that we're not connected with, they can still send you those alerts. That's a really great feature that we've enabled there. We have been in discussions with in a few other states. I'm thinking of like Maine and Illinois, but it's not that we haven't moved forward with connecting them for technical reasons. It's just that our clients did the cost benefit analysis and determined they're not ready yet. But it really depends on like where the healthcare system you are is going, and if it's at a point where it's mature enough to warrant these connections. I 100% think it's worthwhile, and you should absolutely take advantage of it. So having said that, happy to answer any questions that you may have.